director of the newest PA program at Northeastern State University in development. And he's agreed to come and preach for us today, so let's make him feel welcome. So thank you, sir, and I'll see you upstairs.
Okay. Preach, that's a strong word. I don't know about preaching. So you get me for the 3 o'clock lecture. Are you excited? Are you awake? Are you dying? You're like, how much longer? Something to think about. You get so overwhelmed in this program. And as a PA student, you guys are 3 months in? 4, 5? Because I don't see deer in the headlights, but sometimes it pops up and you think, how am I ever going to get through this? It's like I'm in the deep end and I'm actually just trying to breathe before I go sinking under for another breath. So, you know, something to think about. You guys already won. You know, you're here. You're in this chair. There are 15, 20 people just like you that want to sit in your chair. And you're here. Okay? Sometimes you got to be reminded of that. Sometimes you got to think, how am I ever going to get through this? Well, you're here. Okay? So just remember that. Well, so what we're going to talk about is arteries today. You get me on Thursday again for the venous side. But I like the approach that you guys do with the system-based. You guys are all engulfed in cardiology right now. Everything in your world right now is cardiology. So for the next 2 hours, forget about Facebook, forget about email, forget about all the other things you've got going on. I know you've got a mountain of stuff you're looking at going, I got to study this, and I got to go over this, and I got this to do, and I got this, and sometime I got to eat. And then in there I got to sleep. And let's just kind of dive in, okay? Bear with me as I learn the technology here. Okay, learning objectives. Why are those important? Objectives are what's on the test. Okay, these are things that as students we never looked at and never thought to even, it's objectives, whatever, they're boring. Okay, this is what's going to be on your test when you ask instructors, what do I need to know? Well, this is what you need to know. Okay, pathophysiology of everything in every part of the body, in every cell in your body, you've got to know the pathophysiology. It's just part of it. Okay. We're also going to look at some x-rays. I've got some CT images and some x-rays that we're going to kind of review at the end. Any radiology exposure? Some? Okay, good. So maybe that'll be interesting for you. If you haven't seen it, don't feel like you have to be a radiology expert. Okay. What is truly life and death and what is not life and death? That's a big divider. Okay. It dictates how aggressive you become, or how non-aggressive, and how your whole treatment. It just steers everything. So you have to be able to know: is this something that's going to kill my patient right now, or is this something that's going to kill my patient in a month? Okay. So very, very important. Okay. And then we're going to come up with a treatment plan, how we're going to talk to our patients, how we're going to teach our patients to do the right thing, but you know what? They're just not going to do it, probably. Oh, I went the wrong way. Okay, here's what we're going to talk about. Does anybody know anything about these subjects? You ever heard giant cell arteritis? Doesn't that sound weird? Giant cell. That's a funny name. Okay? Arterial insufficiency, PAD, and aortic aneurysm and dissection. Okay? So, giant cell arteritis. Some people call it temporal arteritis. You cannot miss this. Can't. If this is, you know, there's things in practice of oops, and then there's pull out your checkbook. And this is one of those pull out your checkbook, because you miss this one, it's going to be huge. because the result of this one is blindness. And vision is kind of an important thing, okay? So, this one needs to be high on your differential when we're talking about giant cell arteritis. The typical patient is going to be over 50. Each decade from there, it increases in likelihood. So on your board exam, you will have this on your board exam, I promise you. I promise you, you'll have something about arteritis on this. Polymyalgia Rheumatica is, it's an inflammatory disease, but it's below the neck, okay? Can you have giant cell arteritis in the lower body? Absolutely. And it presents with other symptoms. Where does it typically present, though? Is up in the head, temporal artery, okay? We'll go over that. So, what causes giant cell arteritis? We have no idea. We have a lot of educated guesses. We have a lot of theories. There's some genetic, people that have family history. You'll see there's connection. Well, my mom or dad had this, makes them at higher risk. What defines giant cell arteritis is the histology of the disease. Okay? You break it down, you look at it on a slide, and you see these giant multinucleated cells. And there's your diagnosis. Okay? That is how you make the diagnosis. What does it do? It causes damage to the vessel wall. Okay? It causes hyperplasia, overgrowth, and then eventually it occludes the vessel, which when there's no blood flow, that's a bad thing, okay? So here's kind of a slice of the vessel wall, if you will. You can see the endothelial layer. So you have these giant cells that form in that bottom there. Y'all can see it on that side. So, and you have eosinophils. Anybody know what eosinophils are?
White blood cells.
Okay, good. And eosinophils represent what kind of inflammation? If you have eosinophils, you have inflammation, okay? So, naturally you would see those in this. So, if you have high eosinophils, you would expect to have a high white count, right? Not always the case, but likely that's the result. Here's some more epidemiology of it. Women, 2 to 4 times more likely to have it than men. Doesn't mean guys don't get it. It's just unfortunately it's one of those things. So your board exam question is going to be someone in their 70s, a female in their 70s. That's what you're going to see. That's the vignette you're going to see on your exam. It's going to be there, I promise. I don't even know the test, and I know that's going to be in there. So how does this present? Well, the biggest thing is headache. Okay? You're going to see headache. That's going to be pretty much, my head is killing me. Where does it hurt? Well, it hurts right around here, right around the temporal region. Okay? So they're going to have tenderness there, and then they're going to have jaw claudication. What's claudication? Pain. It's a fancy word for pain. So they're going to have jaw claudication. Headache with jaw claudication, highest predicted value for giant cell arteritis. That needs to be right up there with your differential list. Okay? You got to be thinking giant cell. Does that mean that everybody that walks through your door with a headache has giant cell arteritis? No. But you have to remember this. And you almost have to assume most people do, because you have to rule it out. It's just one of those things. When you're working up a migraine, you got to think about this one as an option. Okay? So also the vision changes is what you're seeing as well. Loss of vision in one eye, double vision. Are you having any other visual disturbances, that kind of thing? That's what we're looking for, okay? Because once they're blind, they're blind. There's no going back on that, so you have to catch it before, okay? All right, non-classic symptoms. About 40% of the time, you're going to see these weird, obscure symptoms that are going to present. Dry cough. That's a weird one. Why would they have a dry cough? Anybody have a guess?
Pressure buildup.
Yes. We're going to talk about it a little bit later in the lecture when we talk about thoracic aneurysms and why this is, but this is more below the neck. When they have this inflammation, you can actually get where it can affect the aortic arch. They can have hoarseness, dry cough, these kind of things that can present just from affecting nerve stimulation, pharynx, that kind of stuff. Okay. Mononeuritis multiplex. Anybody know? So mononeuritis is like a bunch of nerves in a group, like a brachial plexus or a lumbar plexus or something like that, and you've got irritation of that area. So like a shoulder, typically you'll see this present with like shoulder pain, that kind of thing. Normal white count prior to steroids, over the age of 65. Idiopathic fever, idiopathic. Weird word for I have no idea where it's coming from. Idiopathic. It sounds really official when you say it. Oh, it's idiopathic. Well, that just means we don't know. But 15% of fevers can also be this, so it needs to be in your differential as well. Okay. So blindness. How does it happen? Typically, it occludes the posterior ciliary branch of the ophthalmic artery. That's when you typically have blindness. Okay? That's just an anatomical thing. We'll look at a slide here in a second. But are you going to see anything on a fundoscopic exam? Well, you can, but you can also, if you catch it early enough, have a normal exam. Okay? So don't rely heavily on a fundoscopic exam. And honestly, whether you're working family practice or whether you're working in the emergency room or wherever you are, unless you're actually dilating the eyes, you're really going to have a hard time seeing the full, having a full fundoscopic exam. It's really hard. So we don't, it's a necessary thing to learn, but we don't put a lot of weight on it, if that makes any sense. So here's just kind of the pathway of how it leads to that. I wanted to just point out where the temporal artery was. That's really the purpose of this slide, is to kind of just make mention of where it sits, why it makes sense why there would be jaw claudication. It makes sense why there would be temporal tenderness, scalp tenderness, that kind of thing. And then, of course, off of that, then you have your ciliary artery that feeds the eye. Okay. So it's once it's dammed up river, everything below that is not getting any oxygen. Okay. So it's just something to think about. Scalp tenderness. So do you see that picture? See how it's kind of engorged? Now there's people that actually have that normally. It's varicosities is what it is, and so it's hard to know. But if it's very tender to touch, abnormally tender, I mean just barely grazing it, this needs to be a high index of suspicion here. Okay. Visual acuity exam. I can't stress that enough. When you get out into practice, you're going to find that your MAs and your nurses and everybody that's there to help you does not like doing visual acuity exams. You got to make them do it. Got to have it. It's important. Okay. Definitely, trying to determine what's going on, you need to have a visual acuity. So remember visual acuity. You can have some findings. You can have hemorrhage. You can have cotton wool spots, scattered cotton wool spots, vegetable engorgement, these kind of things. But just remember that the fundoscopic exam can be normal. So we don't put a lot of weight into it, okay? So what labs do we get? Well, so they've come in, they've got headache, tenderness, jaw pain. What do we need to do? Well, we need to check the inflammatory markers because this is an inflammatory condition. So if you don't check a SED rate on a person with a headache, pull out your checkbook and write a check. Does everyone understand what I mean by that? I mean, that's literally like you don't have any ground to stand on that one, because every other peer that's going to evaluate you on the care of that patient is going to tell you, yeah, you messed up. Okay? So SED rate is just, it's a normal standard. that you should order on everybody that comes in with headache that you feel is not a classic migraine, which that's on a whole nother discussion. But just remember sed rate, okay? Typically, and is it 100%? Nope. So can you have a normal sed rate and have giant cell arteritis? Does that not freak you out? Like, okay, so wait, you can have normal white counts, normal sed rates, and still have this condition. Yeah. So you're going to learn this in medicine, that we practice medicine, so practice makes perfect. But anyways, my point is, the majority of patients will have an elevated sed rate. A more specific inflammatory marker is the C-reactive protein, CRP. Okay, so sed rate is a kind of a general. You would probably hear, and when you get out in the clinical world, you're probably going to hear people go, "I never order a sed rate. We don't do that. That's old." And then you can hear other people that are going to say, "Oh no, sed rates are great. They tell you a ton of information." Well, if you are in Marietta, Oklahoma, in a critical access hospital that's a 4-bed ER and you're by yourself and you have to wait 2 days for a CRP and you can get a sed rate in 10 minutes. Probably a sed rate. But if you're in Oklahoma City at OU Medical Center, you're probably going to get a CRP. Okay? That's my point. It depends on where you are, what resources you have, that kind of thing. Okay? But you are going to hear some variations on sed rate versus CRP, and I'm just here to tell you that CRP is more sensitive. Okay? So in the CBC, what would you expect to see? Expect to see a white count, right? Your differential should show eosinophils. You know, you would expect to see that thing. Not always, but it can happen. Typically, though, you do typically see that. Liver function tests, PT can be elevated. You want to test renal patients or renal function, a UA, and that's because of the other conditions, the polymyalgia rheumatica, and even the arteritis that can affect down in the renal arteries as well. Any artery, large, that was on a previous slide, medium to large vessel, it affects. Okay, so you have to make sure that it doesn't affect the renal arteries. So what's our plan of action? We've got an elevated sed rate, we've got someone with a headache, we've got jaw claudication, scalp tenderness. We're convinced it's absolutely giant cell. Can we make that diagnosis at this point? No, not really. It's like you can be pretty confident in your diagnosis, but it's not the gold standard. Okay, the gold standard is a biopsy. Have to see it under the slide, and you have to see the giant cell multinucleated. That's how you get the diagnosis. Bam, you have giant cell arteritis. But in order to do that, you have to biopsy the vessel. Okay? And you probably won't do that. That'll be something you'll refer. Okay? You also have to think about early referrals to ophthalmology, obviously for the blindness. Questions? Nothing. Okay. Doppler ultrasound can show occlusions, but it's the biopsy that gives you the diagnosis. That's why I made that in red. All right? You're going to send them for a biopsy. That's where you're going to send them. You're going to start them on steroids, which we'll get to that in a second. A contralateral biopsy is recommended if you have a negative. Okay? If you still have a high index of suspicion, they may biopsy the other side as well. You have to make sure it's at least 2 centimeters because skip lesions can occur. So maybe your sample was bad. Maybe you sliced it right where there wasn't any, and then 2 centimeters down, there is some. So you have to make sure your sample is big enough, okay? So here's a picture of a biopsy, if you will. Giant cell arteritis, high-dose steroids. Got to get the steroids going, okay? You're going to start them on the steroids and you're going to refer them. It's really ultimately what's going to end up happening. Unless you go ophthalmology as a PA, which there are, but not very many. But chances are what you're going to do is you're going to start them on high-dose steroids. Okay. Do y'all get into doses, or is it just, do you teach them doses?
We do in pharmacology.
Okay.
We kind of keep that to them. That way there's no big discrepancies.
Yeah, because the reason why we don't focus as much on that is because you may look in one book and it's going to tell you this dose, and you're going to look in another book and it's going to tell you this dose. So I don't want to get into semantics of exactly how many milligrams you're going to prescribe, but you're going to prescribe a high dose. Okay? That's really the take home there. And then, you know, of course, you can consider aspirin therapy. Why would you consider aspirin therapy? Yeah. Can help thin it out so we don't have any clot formation, aggregation, that kind of stuff too. Okay. As I said earlier, once blindness occurs, it is irreversible. Okay? So, patient comes in with headache, jaw claudication, scalp tenderness, and you say, take a couple Tylenol, go home, come back and see me in a week. Okay? Probably not. You want to just, you know, make sure you cover all your bases. Send them for that lab, okay? Even if you're unsure, it's not wrong to order the inflammatory markers. It's not wrong. So polymyalgia rheumatica, haven't really talked about it much, have I? It's not something that you're going to see all that often. You will see giant cell arteritis if you practice long enough, and you either see emergency medicine or family practice, you will see that. So I hope that this lecture, I hope you think about this lecture 3 years from now when you're like, God, what the heck was he saying? So, because it's a big thing to miss, okay? It's a big thing, it's a big deal. A polymyalgia rheumatica is just, my shoulders hurt, my back hurts, my hips hurt all over. I'm tired, I don't want to go anywhere, I don't want to do anything. Well, how many things could that be? A laundry list of differentials. Like, crap, where do I start? Okay? But the big thing is, on this one, there's no actual weakness. Okay? So there's no atrophy of the muscles, or there's no you know, true neurological issue. Okay? So that's one thing to remember. Okay? So treatment for polymyalgia rheumatica is low-dose steroids. Giant cell high, PR low. Okay, big difference. Giant cell, I'm going blind. PR, I'm not going blind. Most, no, I'm not saying most. What did it say? 50% of giant cell arteritis also have this. Call it as just have it as well. Typical taper. I'm sure you're going to get into tapering if you get into pharmacology, bless you. But typically with steroids, we do taper. Even in a Medrol dose pack, have y'all had a Medrol dose pack before? Okay, all right, so you know that the tapering is kind of a normal thing. And then flare-ups can occur, which again, you do another round of steroids. So what's the take home from this? I think I've tried to stress it enough, but this is the down and dirty of what you've got to know. Got to know, okay? Age, headache, jaw pain, fever, vision changes. You got to think giant cell arteritis. It has to be in that differential, okay? All patients should get a SED rate or a CRP, depending on where you are. Don't forget it. Look at their history. What happens to the blood vessels if you have diabetes? Anybody know? Haven't got there yet, I guess. So it ruins their vessels. You'll find that patients with diabetes are going to have some kind of, which is funny when you watch TV and you see these ads for Amendia and some of these other diabetic medications. If you've suffered a heart attack and while taking this medicine, contact this law firm. You know, and it makes me laugh because diabetics are. It's just being diabetic makes you a higher risk for all the vessel issues. You know, I have a hard time cluing it to one medication when you have diabetes. Get them to an eye specialist right away. That's not, go see them next week. It is, hold on a second, I'm going to go and I'm going to make an appointment and I'm going to call that doctor and I'm going to say, This is Troy Bender, I'm a PA, I've got a patient I need to send over to you. Can you get him in today? Can you get him in the next hour just to look him over? No. Come on, you can fit this one in. Make him fit him in. Can't fit him in? Hang up the phone. Call the next one. Okay, I mean, that's what I'm trying to get at. Don't say, well, as soon as they can get you in was a week from now. Don't do that, okay? Get them in. Physical exam, I think we've kind of talked about that. Tenderness with palpation. Gold standard, what's the gold standard for diagnosis of giant cell arteritis? Yes! Y'all are all going to get that question right. Should be 100% on that question, because that one will be on your test.
Okay.
Steroids, and more steroids. Pretty much what your options are, steroids. So what's the treatment?
Steroids.
Golly, that was good. Okay, moving on. Arterial insufficiency. Well, the arteries ain't working right. The blood's not moving like it should. I have to have my caffeine. Y'all had your donut. Now you're on that glucose crash. Now you're like, crap, I need another donut. If you need another donut, come get one. So we got to do some terms here. We have to know what we're talking about, right? When we say the word claudication, and when we say these other weird words, idiopathic. We have to know what we're talking about. Thrombus, solid mass of platelets that forms in a stationary vessel. Okay? Emboli is a piece of thrombus that has broken free and travels through the bloodstream. Okay? So you've ever heard the word embolic stroke? Okay. So it's worked its way up, and it got to a smaller vessel where it can't pass and it's stuck. Okay. Thromboembolism, that's what it is. Okay. What's the definition of arterial insufficiency? Well, when the dam is occluded, everything past it ain't working. Now, you have collateral blood flow. Don't know what that is? So you got little rivers and streams around that can take some of the excess blood, but those little rivers and streams can only hold so much blood, right? I mean, they have a finite amount of volume that they can hold, and beyond that, it's about all that they can do. So it is possible to get some perfusion that way, but if the little rivers are not very big, it's not going to move much blood. Okay? Can be acute or chronic, depending on what artery we're talking about. Okay? That's really what it is. We're also talking about how much occlusion. I mean, if we have an occlusion of the femoral artery, we have a problem. We have a big problem. Okay? It needs to be dealt with. Can be secondary to thrombosis. I think we covered those. We kind of know what that is. Trauma. Why would trauma cause this? Any ideas? What's that?
It can like dislodge the clot.
So in trauma, you can have some coagulopathy disorders that can happen just from the process of it, and you can develop clots just from trauma. Also, if you're not moving around, recovering from trauma. Oh, personal experience?
No, we haven't moved around, so.
Oh. You've heard of the blood clot formation from airplane rides.
They're all like,
Happens with students too. Just don't throw a PE, okay? I don't really want to deal with that right now. Do like what they're doing in the back. Stand up and go back there. What a cool thing to have back there for you. Where you can just get up and stand. So no excuses in the back row there.
I'm short of breath.
Typically, this is an over 65 kind of age group. You don't typically have somebody like you that presents with this. Does it mean it can't happen? No, but typically you'll see them, they'll be over 65. So leading cause of limb loss in the elderly. Makes sense, right? The vessel occludes, it starts to die, the tissue don't get fed. We have problems. Risk factors. tobacco use. Why would tobacco use be a risk factor? Yeah, big time. And vaping is not any better. So wait till you get out there and have to explain that to your patients. No, vaping's better. You won't get all the tar and all the. No, it's better for us. We don't have to breathe all that crap in. It's just, but for them, no, it's not any better. So right, excellent, nicotine. Endocarditis, any ideas there? Endocarditis can affect actually some of the vessels in the bowels. You can release clots from endocarditis. Okay. Diabetes, we talked about, their vessels are screwed. It doesn't matter what it is. If they're diabetic, all the vessel issues are going to be on your differential all the time. To include MI, stroke, all that stuff. Okay. Drug abuse, yeah, IV drug abuse, cocaine.
It's also
And you'll always get, yeah, exactly. You'll always get, I don't know how that came into my system. Somebody must have just put it in my drink. I don't use drugs. I've been clean 10 years. Are you sure you tested the right urine? I get these all the time. I get that one. Are you sure? Yeah, I'm sure. Maybe your test is wrong. Anyways, cardiac arrhythmias. What one in particular?
AFib.
AFib. Golly, good job. I was hoping you guys were going to jump right on that one. Okay, and then trauma again. Atherosclerotic disease. I think we kind of get that one. I mean, that one's coming. So clot in arterial circulation due to platelet aggregation, adhesions, genetic trait. So if it happens in the heart, you're going to have chest pain, you got to think heart attack, that kind of thing. If it happens in the brain, stroke, that kind of thing. Typically though, it's going to live in the lower extremities. That's the LD. Severe claudication. Literally, you get your patient up and you say, I want you to walk to the other side of the room. How big are those rooms? 5 feet? 6 feet? And literally by step 2 or step 3, they're literally in so much pain they can't continue. That's what I'm talking about. I'm not talking about, I ran a marathon. How many marathon runners are there? Good for you. If I ran that marathon, I would not be able to walk for a week. I probably wouldn't make any sense, but I'm not talking about that kind of thing. But severe claudication. Mesenteric arteries, when you guys get your surgical rotation is when you're going to see this a lot. If you do emergency medicine, you're going to see this a lot as well. And this is abdominal pain out of proportion of the physical exam. Literally, like, just the thought of you touching their belly is making them jump off the table. There's a problem. Now, some of that can be a little bit over dramatic, but you got to be thinking, okay, something's not right here. If I can't even lightly palpate, I can't even listen. They're not even letting me put my stethoscope on their belly. Something's big, bad wrong. Okay. And then renal arteries. There's that RAI is Renal Angina Index. It's a classification where we look at the function of the renal arteries and the function of the kidney. So how do we test for the function of the kidney? Creatinine, GFR, and one more, BUN. Good job. Good job. That's what we're looking for. More specifically though, which one is the most specific? Yes, exactly right. All right, so we've got different classifications, American College of Cardiology, AHA, they've come up with these different divisions. So asymptomatic. Is it possible to have arterial insufficiency and not have pain? Okay, think about your diabetics that step on a nail a week ago and have no idea they have a nail stuck in their foot. Okay, wait till you get to do some of those foot exams. Oh boy. You'll think, why did I do this? Why did I do OPA? It's not that bad, but anyways. If you have a feet thing, I don't really like looking at feet. I look at it from across the room. Yes, that looks bad. Okay. I would never be a podiatrist. But, so it is possible to have that. Claudication, we already talked about. Lots of pain with exercise. Critical limb ischemia. So we've got blood flow compromise, and it hurts all the time. It doesn't matter if I get up and walk across the room for you, or whether I'm sitting in the chair, it's still hurting. Well, what else could cause that? There's quite a few things that could cause that. So we have to look at some distinct findings to differentiate between arterial insufficiency and other things. But the big one is acute limb ischemia. This is, if you don't fix this, they're fixing to lose their leg or their foot or their ankle or their knee, or they're fixing to be an amputee, okay? And these are big, major vessels. The 5 P's of pain. Y'all love mnemonics, right? That's how I made it through PA school, making up mnemonics, okay? Paralysis, paresthesia. Paresthesia is numbness and tingling, pins and needles, okay? Pulselessness, that's kind of important, right? You don't have a pulse. You have a pulse, a good dorsal pedis in one and nothing in the other one. We have a problem. If you can't feel a pulse, what would be the next step? Get a Doppler. Usually your office will have a Doppler. Besides screaming down the hallway, just go find the Doppler, come in, and sometimes it's hard to find it. Okay, but if you don't have a Doppler pulse, and you've got a purple foot, we got problems. Okay, so it's kind of blurry. Can you see those pictures? Okay, you can definitely tell those 2 feet don't look the same. I'm not a foot guy. I can see that from across the room. I don't got to get up there. I can tell. There's problems there. Right? But the other one, pale, bluish skin. Has anyone noticed their feet turn blue when they're sitting or walking? No? Yeah, y'all aren't old enough yet. That happens just with, as you get a little older. All right, so what do we want to order on this person? We got to order labs on everybody because we got to charge them, right? So we got to figure out what we got to order. That was meant to be a joke. Okay. Delayed. Okay. CK, CKMB, and troponin. Those are your cardiac enzymes. Got to order those. PT-INR, PTT. Have they broke these down of what measures what for you guys yet?
Yes.
Okay. Why would you want to do an ABG? Any ideas? Well, it's instinctive to think ABG oxygen. But ABG represents acidosis. So in order to make a diagnosis of acidosis, we have to have an ABG to make that diagnosis. That's what gives us our pH. Okay? I get where you are because that's normal, that makes sense. We order ABGs on people that can't breathe, right? And yes, that's part of it. But what about your diabetics? Got a guy with a blood sugar of 700. You should be ordering an ABG because you want to see, is it ketoacidosis, is it not? Okay, so again, ABG, think acidosis, CBC, CMP. I think that's pretty well y'all get that one, right? CMP versus BMP. The CMP is going to give you your liver, right? Okay. UA, lipids, sed rate, CRP. There's that dang sed rate again. Why would you want to know lipids? Someone with a pulseless foot, why am I testing his cholesterol? Yeah, that's right. Good job.
Do you guys understand that a CMP is a BMP plus the liver?
Mm-hmm.
So it's embedded in
yeah.
it. Okay.
So it gives you a few others, gives you a calcium that a BMP doesn't. But the biggest thing difference is some people, like back in the day, a while ago, it used to be called a Chem 7 or a Chem 12 or a Chem 20. I don't think they call it that anymore, but it used to be called that based on how many you would get. Anyone ever heard that?
Yeah.
Oh, right. Okay. All right, but yes, a
2
CMP
weeks ago.
gives you BMP plus it gives you your liver, calcium, like your albumin, pre-albumin, yeah, something like that. Okay, so we have to charge them for labs, now we got to charge them for x-rays. This is where the bill gets big. This is where you get your money. This is what pays your salary. So, what do we want to order? We want to order the most expensive test on there. So CT angiography, that's going to light up the vessels. That's really going to show us, you know, what's narrowed, what's occluded, that kind of thing. You can also do a Doppler or an echo. Doppler will also show you blood flow. You can get a index. They'll calculate those indexes for you. You don't have to calculate that. You're not going to calculate an index on a board exam, or so just know those will be calculated for you. You got to know the numbers. You got to be able to interpret the test, which we'll go over. Okay, so if I have an occlusion in my left femoral artery, would you think that my blood pressures are going to be different?
Yes.
Yeah, it makes sense, right? Just like coarctation. Have you guys talked about coarctation?
Yeah.
Okay, kind of the same thought here. So if you have a blood pressure on can you take a blood pressure on a leg?
Yes.
Okay. All right. So if you've got a blood pressure change in your legs, this should be high on your list. Okay. Now, coarctation, you typically see changes in the arms, but if we've got changes in the leg, you got to think about arterial insufficiency. Okay. What does that thing say? It says mild. God, it's kind of blurry. I thought these would be clear, but I guess I blew them up too big. Can y'all read that okay? Okay.
This big screen always looks better than that one because I've done the same thing.
Okay. All right. All right, what are we going to do for them? We're going to pick up the phone and we're going to call somebody, right? Hey, we got a problem here. So we're going to start them on blood thinners. All right? Does that mean we start them right on Coumadin?
No.
Why not Coumadin? Everybody's doing Coumadin. Coumadin's cheap, easy. What's that?
Doesn't it take a little while?
Yes.
With the titrator?
Gold star there, good job. Okay, yeah, Coumadin takes a few days. That's why they recommend like a bridge. But in this case, heparin is really your game winner here. Okay, so heparin is what we want to do. We want to get rid of that clot. We want to lyse that thrombo. Okay, however we do that. There's a lot of different ways to do it. We can stent it. We can go in there and rotor her out. We'll talk about here in a little bit. Okay, the goal here is A, I don't want it to get worse, so we're going to thin their blood out. And B, if it's occluded, we got to figure out how we can return blood flow. Either we have to go around it, or through it, or something. Something's got to be done. That's where the foam comes in. All right, so you have to know this list, okay? This is kind of one of those things that, this is one of those pull out your checkbook, you screwed up, okay? This is one you don't want to be giving somebody thrombolytics that just had a stroke, okay? Sorry. Pull out your checkbook and write a check, because that's what that one's going to be, and that's going to be a big check. So, y'all can read the absolute. Absolute is in red. Does that mean maybe? Does that mean like, well, they had that, but it's been, no, absolute is like, deal is off, okay? Now, relative contraindications, this gets thrown back on the patient. You as a clinician, in your lab coat, walk in and say, well, you have this bleeding disorder, but it could work, it could not work. It could kill you, it could do this, it could do that, it could do this. So, would you like to do it or not? and you let them choose. Your job as a clinician is to educate your patients, allow them to weigh the risks with the benefits. So that means you got to know what the heck you're talking about, and you got to know how to present it in a way that makes sense to them. Okay? Because these are not necessarily game changers. These are risks that could be bad, or it could be insignificant. But you've got to get it communicated well to your patient. Okay? So, peptic ulcer disease, GI bleed, uncontrolled hypertension. How do they know if they have uncontrolled hypertension?
If they have hypertension or not medicine.
Or they just have no idea. They're walking around with 180 over 90, and I only go to the doctor when I'm sick. I don't go to the doctor except when I'm sick. Well, you'll hear that one. If you had $1 for every time you heard that one. So, you know, they could have been walking around with blood pressure and they didn't know it. So you're seeing for the first time in the emergency room and they have 180 over 90, and you're like, well, you know, how often do you go to the doctor? How often do you stop at Walmart and sit down in the little booth and take your blood pressure? How often do you, how often do you check it? Do you care about your blood pressure? I smoke and I drink and my mom and dad did that, they lived till they were 90. Okay, so again, so that's the way the risk. So I can't speak for your blood pressure over the last 10 years. I don't know you. I don't know if you've had high blood pressure, but you need to know that that wears out vessels, that weakens vessels. And I'm about to thin your blood that you can have a kind of big bad thing that's fixing to happen, okay? So make sure you make that one clear. Pregnancy? Yeah. So how bad do we need to give them this thrombolytic? You know, I mean, that's what you have to really know. You have to be able to communicate that to the patient. Explain to me why I need to risk my baby and my life for this medicine. Why do I need this medicine? All right, the take home again. See, y'all are going to know this. You don't even have to study it. You're going to be like, oh yeah, I got this down. Genital arteritis, good. No, you still got to study. Sorry. There's more to this than just what I'm presenting. This is kind of just skimming them. Do y'all have the big Harrisons? You make them buy the big Harrisons? Oh God, big Harrisons is like a 100-pound encyclopedia of every condition known to man. That will make your head hurt. Probably have it online. You have it online? Y'all are so lucky. I'll lug that one around forever. But Harrison's is a wonderful reference. Y'all use Current? Okay, Current gives you really, I like Current better. I think it gets deep enough to really what you need to know. But if you ever want to go above, Harrison's is your answer. Okay. Okay, so that will be sudden pain out of proportion. Remember we talked about that? That's a this should be a high index of suspicion here. Because we're dealing with arteries, we're not dealing with veins, we're dealing with arteries. The good stuff going out. Okay? So, pain out of proportion, the 5 Ps. Okay, remember all those. And then acute limb ischemia, that's the big deal. That's the pick up the phone, get somebody, we need to get this patient treated now. Unequal blood pressures, thrombolytic therapy, I think we talked about those. Educate your patients. Know the risks. They're looking to you for those answers. Okay? You might be it. Now you're going to say, oh, I'm a PA. I've got a physician that's got my back. Well, if you're in rural Oklahoma, which there's a good chance, if you want your education paid for, you're going to be in rural Oklahoma. And you might be it. So don't always think you've got a backup. You need to know this stuff, and you need to know it well. You need to be able to make these decisions. So know your thrombolytic therapy. Okay? How are we doing? Anybody need a break? Good. Keep going. Get this done. Fire through. All right. Y'all yell at me if you need something over a break or gotta go bathroom or something. I just keep going. All right, peripheral arterial disease. Peripheral arterial disease. So we're talking about out in the periphery. Okay. Why is that in red? That's important to know. You need to know that. I'm guessing that's going to be on a test. I don't even know the test, but I'll bet you that one will be on the test. Because you might see that one on boards. Okay? Because you're going to order this and they're going to give you this calculated value. Well, who gets to read them? You do. Not your physician, you do. All right? Typically over the age of 40, males, females, 2 to 1. So, you've got a plaque formation, something causing inadequate blood flow, and you have failure to meet the metabolic demands, and when you have failure to meet the metabolic demands, you have acidosis. And when you want to check for acidosis, you order a ABG. Okay, good. All right, and you'll have claudication, that kind of stuff. Ran the marathon. I ran the marathon. I would not be able to get out of bed for a week. So they get this, y'all have been probably drilled this one from cardiology, you know this one, right? Okay, I'm not gonna revisit that one then. All right, look at those arrows. That's the take home out of this one. You typically will see peripheral arterial disease out of the superficial femoral, deep femoral, and popliteal arteries. 80 to 90%? Holy moly. That might be important to know. Intermittent claudication. Symptoms usually resolve within 2 to 5 minutes after the patient rests. Sometimes not. Sometimes it just stays all the time. But this is, I mean, we're not talking when I get out and exercise and run. This is, I get up to go to the bathroom. I get up to get dinner. Hurt. Erectile dysfunction. Well, unfortunately that happens. And it's a vessel that affects that. Okay? And the vessels can get narrow and not flow good. Okay? So think about that as well. Numbness, tingling, paresthesia, skin changes, ulcers that won't heal. I've got this thing on my foot. It's been there for a month and I keep putting salve on it. Everybody wants to put salve on things, huh? Salve. I'm going to put salve on it. I'm going to put some dirt in it. I'm going to rub some dirt. I'm a man. I clean things with dirt. Actually, I had a guy do that. Ulcers that won't heal. Gangrene. Has anyone seen gangrene? You have not lived until you've pulled a homeless guy's sock off and his toe is in his sock. Oh. Seen that one many times. You're like, oh, finally fell off. It fell off. That's a raisin. It's not a raisin. It's not a raisin. Not a raisin.
Anybody hungry?
Yeah.
So, dry skin, pale. Pale when elevated above the heart, you know, so there's not enough get through. Even when you elevate it, it's turning white and blue, and that's not good. Hair loss, sock line hair loss. You're going to hear that a lot. You know, you're going to see patients with it. Y'all's dads probably don't have, you ever look at their feet?
Good shepherd.
And you think, he doesn't have any hair on his legs. Why doesn't he have any hair on his legs? Does he shave his legs? No, he does not shave his legs. Hair requires blood flow in order to grow. Okay, so just know that. So when you have patients that look like they have shaved legs, they are not shaving their legs. Okay, that's a real common one. That's why I made that one red. It's important. Muscle atrophy. Yep. Barui, what's that?
Turbulent sound in the
Turbulent sound. So that's the textbook definition. Anyone heard it?
Yeah.
Okay. Did you hear it?
Oh,
That was a murmur.
That's okay. All right. So
Similar.
I say this, you're going to hear lots of nothing. And then there's going to be one day where you're going to hear this and you're going to go, whoa, wait a minute. I've heard a million nothings, and now I'm hearing something. And you'll get confirmation from somebody who's heard it before, and then you'll go, oh, I've heard it finally. And you've heard it, okay? So don't, someday you're going to hear it, I promise you. And when it stands out, when you've heard a million nothings, and all of a sudden you hear it, that one's going to smack you in the face. It's a feet thing again, I just don't, you know, from a distance that looks bad, right? What's that middle one got in it? Yeah, that's that raisin. It's not good. What's the treatment for that?
Cut it off.
Get some scissors, give them a stick, bite on. No. Okay. How many have seen the one on the right walking around at the fair or something like that?
It's coming up.
Right? They're like, oh, yeah, okay, I know that one. So now you know that one. You see the big ulcer on it? Let me go back. You see the big ulcer on it? Yeah, that's what's it. I put some salve on it, it's not getting any better. Okay. So there's different stages of classification. The one that is probably the best to know is Fontaine's stages of classification. There's other ones out there. I don't think this is the only one, but this one's good. Stage 1, always good to have stage 1 in anything. Stage 1 is good. Okay. Stage 2, intermittent claudication again. They've got a 2A and a 2B. Okay. So, got to know the differences between those two. Stage 3, rest. Now, why are these classifications important?
How you treat?
Huh?
Is it how you treat?
Exactly. Good job. Dictates how aggressive you are in anything, in renal failure and anything else. However they're classified, however they're stratified. Also for your diagnosing and your CPT codes and stuff, yes, this is important. But it dictates how you treat, how aggressive you are. Okay? All right, so what do we want to know? We want to know if they're diabetic, right? Because diabetics have what? Wonderful things? So, how do we diagnose diabetes? Hemoglobin A1C, that's right. So, if you have a high glucose, you have a suspicion, but it's the A1C that really gives you it hammers it home, okay? That's the absolutely, you have diabetes. You want to understand what A1C is? Hemoglobin A1C measures the glucose over the last 3 months. 3 months? How do you know 3 months? The lifespan of the cell. Ugh, you guys are good. Okay, so that's the lifespan of the red cell as the glucose attaches to it, and it gives you an average. And whatever the A1C number that comes back, it's going to give you estimated regular blood glucose associated with that. Okay, so it'll tell you where they average because, of course, it does this, right? So we want to know where it averages. Okay, so again, diabetics is a comorbidity. Fasting lipid profile, that makes sense, right? Okay, all right. Does this all matter if we've got a toe that's fixing to fall off, or we've got a, big major occlusion of big vessel? This is a stage 4. It matters, but it's not like the first thing to do, but it's, oh yeah, we got to put that order in to get that, but it's not really where we're going to be at first. So again, the stages, it dictates how you treat, okay? So how do we do this? Well, we do a flow imaging Doppler. We do angiography, contrast angiography. In the images at the end of this, when we go over some of them, you'll understand why we do contrast. Contrast just, it's like, it lights it up so nice you can see it really easy versus non-contrast. So anytime you are ordering a CT or any kind of imaging study and you're looking at blood vessels, think contrast. Contrast, blood vessels. Blood vessels, they're together. They're married forever. Okay? Well, what happens if what patients can't get contrast? Yes. More specifically, creatinine. And you hear different hospitals have different numbers. Oh, it can't be above this, 3.2, 2.0. These, you have different numbers. Well, they actually have different types of contrast. That there's now studies coming out that's saying that even patients with impaired renal function can still get these contrasts. There's different kinds of, but not everybody's on that bandwagon yet. And you'll learn in evidence-based medicine, it takes a while for things to kind of change. So you might meet a lot of roadblocks in patients that have this. So what do? You have a patient that you suspect that's got a creatinine of 3. What do? You order a Doppler ultrasound. So you've got other options, okay? But angiography, best way. There's that index again. Oh my goodness gracious. I gotta know the index. I gotta know it. Treadmill exercise test, looking for changes in the index, flow changes. So we get them up there and then make them run. Run that marathon. All right, so now you're the educated one in the lab coat in the room, and you're saying, don't smoke. Well, I only smoke like a half a pack a day, like one every couple hours. So they may not listen to you and don't be offended, but you have a responsibility to educate your patient. What do they do with that information? It's up to them. I'm up here, I could just be, y'all could be, y'all could be in some other place, and I'm up here, all you hear is wow, 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 it's up to you what you do with the information. Whether you choose to go home and study it and learn it and know it, it's your choice. But we're here telling you, right? We're educating you, getting you educated. Diet, what can diet do? Does it matter what we eat?
Yes.
Yeah, it does. So, but you would be amazed. I did my general surgery rotation, and I was with a bariatric guy, but of course gallbladders is their bread and butter. And I had this lady with like gallstones that were like a little bag of marbles. I mean, her whole gallbladder was just full of marbles. And she said, I don't understand. I've been trying to lose weight. I can't lose weight. When I go to Burger King, I order the chicken sandwich instead of the Whopper. And I get the small fry instead of the large fry. So you can't laugh and you can't, but seriously, that's where their brain is. Okay? So sometimes simple little things can help them understand, like drinking Starbucks is bad. Exercise, of course, that helps with blood flow, that kind of thing, okay? Foot care. Ew. I don't like feet. You figured that one out probably. But appropriate shoes. Does anyone have high arch issues? You have plantar fasciitis? Ugh, it's the worst. Shoes nowadays just don't come out with any arch support. You have to go get. Do you have inserts?
No, because you have to break in the inserts, and that makes my feet hurt, so I'll just deal with it.
She's absolutely right.
Yeah.
Because when you pull out the nice flat one, then you put in this big thing. Yes, it makes the shoe tighter. So you almost have to get like a wider size, or it makes it hard. But you'd be amazed how much just simple foot care and stuff can help. Oh my God, there's that pharmacology word. Let's just switch right. All right, so antiplatelet therapy, aspirin. I think we all understand that. Clopidogrel. Y'all need to know it that way. What's the other name for it? But on your test, it will say clopidogrel. That's what you need to know. Okay. Statin therapy, prostaglandins, clopine. Bypass surgery and revascularization, PTAs. So Roto-Rooter, or we got to go around it, okay? So we've now gotten our CT angiography back, we've got our index back, we put them up on the treadmill, we see that we have an occlusion, or we've got a flow problem, we need to deal with it. So now we're to the, how do we fix it, okay? we either need to do a bypass or we need to go in there and try to clean it out, okay? What happens if you clean it out? What risk is there?
Getting it back.
Yeah, well, but the, all kinds of issues, but a plaque can break away. Where's that gonna go? Right to their brain or their heart, guaranteed. All right, so complications. In my previous life, I was a paramedic for 15 years, and I was a flight paramedic for 8. And we would get called all the time for complications of this procedure, where they would stroke out or have a huge heart attack and be coded, and they don't know why. They just came over this routine then pop bypass. So graft occlusion can happen, infection, massive bleeding. Can bleeding happen from this? That's especially, I don't know what vessel we're dealing with. And so limb loss. All right, Roto-Rooter, PTA, percutaneous transluminal angioplasty, less invasive. Again, this is location, location, location. How easy is it for them to get to wherever this is? Okay, that determines this one. Okay, it's less invasive, obviously, right? Cheaper, but who cares about that, right? It is the appropriate first-line therapy in the iliac arteries because it's just so easy to get to that. It's kind of the easiest one. So what do? They go in there with this cannula, so they have to cannulate the artery, right? Because this is in the artery. Well, what's going to happen when you cannulate the artery? So all kinds of issues can happen. But you can see on the right, you see the before and after, right? See those images. They get in there, they have this balloon that kind of just moves it all out to the, squishes it out, and then they deploy this stent. And that stent stays in there. Will that stent occlude?
Okay.
Yeah. So that means they're going to be married to Plavix for quite some time, or Coumadin, or something like that. Here's your complications. So when this patient says, why do I need this PTA? Well, you need it for this. Well, what can happen? This you have to talk about. If you don't mention it, and in any consent form, you're going to see this listed, and if they're not listed on there, and one of these happen, they're going to come back and go, well, you didn't tell me that this could happen. Yeah, I did, you just weren't listening to me. Because why? They're a little overwhelmed, right? They're going to remember everything you say. Your patients will not remember things you say. So I have to write it down for them. So that's why it's on the consent form. So use the consent form as your checklist when you're talking about complications. Groin hematoma. So, stick the artery, I run it up there, fix it, blood flow does great. Now I yank that catheter out. What can happen? Well, there's a hole where that artery was, where that cannula went, and it's all out into the spaces. You actually have to put a compression on it for a good amount of time, and then they move around or something happens, or they don't get it on the right spot. Then their pelvis is full of blood. That's a problem. Can you lose a lot of blood in your pelvis?
Yeah.
Like all of a sudden you have a blood pressure of 60/40? What? Yeah, so. Pseudoaneurysm, AV fistula formation. It's like AV fistula formation.
So the fistula is an opening between two things you don't want to open.
That's right. Fistula is a communication that has created, okay, arterial venous fistula. All right? Because anastomosis, that's a weird word. Anyone heard that one before?
Yeah.
Oh, man. So anastomosis can happen after you injure a vessel, and that can create a fistula. Arterial rupture, we talked about. Distal embolization, absolutely, it's going to go to their brain or their heart somewhere. Their mesenteric artery, what's going to happen then? Their belly's going to be screaming, pissed off, hurting. What we need to know, that ABI's on there, might be important. Most commonly, femoral and popliteal arteries. That's where you're going to see it. Where are you going to see giant cell arteritis? Temporal artery. Okay. make sure you're staying awake. 4 o'clock. Okay. Are we doing good? Need a break?
Yeah.
Break? Break. All right, let's take 10 minutes.